So then what happened? Well, just in the telomere length, so that was something that we had before. So we had MRIs in telomere length. Those were probably the strong biomarkers of aging outside of triglycerides and HbA1cs and things like that. We just saw like a cascade of benefit. My telomeres, so we use life length and SpectraCell. In SpectraCell, I think pre gene therapy, my telomeres were like 6.8 or something like that. This year they're 10, and they just keep going. And we released a paper in 2022 on my telomere length. It was a peer-reviewed paper that came out to show that for every year after I received the gene therapy, my biological aging by telomeres went down about 5 years. And it had a big bump at the points where I would redo the gene therapy. So that shows us that probably the first gene therapy is persistently lengthening the telomeres. Now, this isn't only in the T lymphocytes because that's what they test. Doesn't mean that's the only place the gene therapy went. But then doing more gave us even another drop in biological age that is more less subtle. And then they continue. You can either think of my telomere lengths continue to go up, or my biological age by my telomere lengths continue to go down.
Hello, Liz. You are the founder and CEO of BioViva. So welcome to Modern Healthspan, and thanks so much for joining us again today.
Thanks for having me. It's been a minute since I've seen you, and I can't wait to talk about the things that have changed between the last time we spoke, which was how many years ago?
I think it was about 3 years ago. You
Okay,
were
not too long.
not too long. But you were one of our very early interviewees. Very kind of you to join us. Thank you very much. So, yeah, that was great. Um, but Liz, kind of as an intro to yourself. So you have, I think, very bravely been this N of one who has taken these gene therapies some years ago. Could you talk through which ones you've taken and when you took them? And yeah, so how has it come out for you so far?
Wow, because it's been a while, even since the last time we spoke. So
Hmm.
that's right. So we started BioViva with the audacious idea that things that had sat too long in research needed to translate to humans, and that potentially millions of humans were dying unnecessary of treatable diseases. So when we started the company in 2015, I was the first recipient with a T of two gene therapies. One was telomerase reverse transcriptase, and I was the first human to receive that. That's a gene therapy that lengthens the caps at the ends of your chromosomes. And then the second gene therapy was follistatin, and that was a gene therapy that had been through safety and efficacy with Duchenne's and Becker's muscular dystrophy, and we thought that it would be a great multi-purpose tool for sarcopenia. Then the company expanded, and we decided to target more aging-associated diseases. So, as my credo to the company to take the gene therapies before other people would take them, outside of something that's monogenic. Sometimes we have to make gene therapies for people who don't qualify for clinical trials, and it might be a gene that I wouldn't take because I already have a healthy copy of it. So we have to disclude that. But we decided to do a study with patients with dementia, and we designed a protocol for intranasal delivery of Clotho, alpha Clotho specifically, and telomerase reverse transcriptase as a dual gene therapy. We actually, in some of the participants, we did three gene therapies, but only because they had different vectors, so they were targeting different cells of the brain. So let me see, it was 2020, I took intranasal Clotho, IV Clotho, injected PGC1 alpha, telomerase reverse transcriptase again, and follistatin again. And then fast forward to 2024, I took another dose of Clotho because we were testing a protocol for redosing. And then most recently, I took telomerase reverse transcriptase, clotho, and follistatin again. And then I'm making a couple of new gene therapies, but we're not going to talk about those until they have been given to a recipient, which will probably be me.
Right. So I was interested in, I was going to ask later, but follistatin. So follistatin helps you build more muscle, but um, it seems a strange choice for an early gene therapy because it seems like there's more urgent problems than sarcopenia, and you can build muscle with like peptides or there's other ways of solving that. So why? And not only you have taken follistatin, but I know that like Brian Johnson has also taken follistatin. So is it just sarcopenia, or does follistatin provide other benefits?
So he's taken a different type of what might be called a gene therapy, a plasmid gene therapy. It's a short-acting gene therapy. We do the long-lasting gene therapies because they're explained well in literature and they're the ones that get through the regulatory system thus far. So there's a little bit of differentiation there. And why would we do that? Well, sarcopenia is a cost to society. It ends up with patients falling. That's usually, if something else hasn't killed an elderly person, that's typically the last major incident that happens to them before they die. Just in Australia, paper, I put out a lot of papers if anyone wants to follow me on social media, but in Australia alone, it costs the healthcare system over $300 million a year just dealing with people who fall in nursing homes. So it is a burden to society. And why would we want to treat aging associated diseases? Because we want to recoup that loss of function because just living a long time in a wheelchair isn't as fun as living a long time with your physical capability. And then why would we look at gene therapy? Because gene therapy has the ability to scale and become affordable. And when I talk about the vector delivery that we do, that's a long-lasting gene therapy. So for a patient who is old or who doesn't like pills, like me, you would just need an injection maybe once every 10 years. And that really is a differentiation factor. Right now, the cost of gene therapy is expensive, but if that was affordable, most people, especially people who are aging in different ways and wanted to be stronger but couldn't afford every therapy, you would want to give them something that they wouldn't have to redose over and over again.
Okay. So you took these therapies some time ago. In fact, well, you took some last year as well.
I took
So
some this year.
you took some this year. Wow.
Yeah. I'm just like on the recovery from that. So I guess we would call that a recovery period. It doesn't really feel like much of a recovery period, but I'm still in the within 1 month of doing that. So this is, still the phase of um, capsid release, although most of that is gone within 2 days, and getting off of immune suppressants, let's say.
Okay. How are your why do you I was just thinking, why do you need immune suppressants if you have gene therapy?
Oh, that's a good question. And I led you right into that. So, we use immune suppression in gene therapy, especially after you've already had your first gene therapy. We're the first company in the world that is able to redose humans and show upregulation of the benefit of the gene therapies. I don't think any of the major pharma companies have ever done it. We've been a first to do a lot of things. And so building protocols for redosing is really important to us. And then, on our research and development side, we're working on cytomegalovirus. So it's a virus that exists in nature. We make it so it can't infect you. We make it so it delivers healthy genes, and its redosability has been shown in a paper that we put out in 2021, I think, with Rutgers University. But In the meantime, because we already work with AAV, we've been working really hard to redose it. And so an immunosuppressant regimen is required even if you do a gene therapy for the first time, but we are exacting how to do it a gene therapy multiple times and actually use less immune suppressant to do it. And so it's pretty revolutionary.
Interesting. So it's because of the virus that you need to suppress the immune system.
It's actually a few things. So it's not just the virus. The virus, remember, is attenuated. Your body could see it as an invader. So that's one reason that we would use immune suppressant. The fluid in which the gene therapy resides in can cause an immune response as well. And then, of course, we want to make sure that those genes that are going to make you healthy for a longer period of time are not associated with any of those substances. So we want to tone and turn down the immune system so that you don't have a cytokine response to the gene therapy itself.
So you mentioned,
It's not so much that you can't go on an airplane. I mean,
right.
you should probably wear a mask if you go on an airplane, but it's not the amounts that they use in other diseases is much higher than we would use in gene therapy, believe it or not.
Okay. No, that makes sense. So you mentioned that Brian Johnson used a different type of gene therapy. I mean, just out of interest, would you be able to explain what the difference between the gene therapy as per BioViva with the adenoviruses and the one he did?
Yeah, so there's many ways actually to deliver genes and CRISPR. Generally with CRISPR you use AAV, which is what we also use to deliver genes, but when we do it, we're not looking to integrate or affect your chromosome at all. When you use a plasmid gene therapy, the gene goes into the cytoplasm of the cell and the machinery in the cell reads it. And the cytoplasm is the bigger part of the outside of it. With gene therapy with vectors, it goes into the nucleus. And when you go into the nucleus, the genes get the protection that the chromosome receives. And so it has a longer term expression. So it's a long lasting gene therapy.
So you took which was actually where I was going in the first place. So you took these gene therapies a number of years ago, right? And you continue to take. So how are your biomarkers? And do you take your epigenetic age? Because you are looking very good, I have to say.
Oh, thank you. Yeah, so let me do everyone a favor that is watching. Some of the testing for biological aging is still in the works. Some of it needs some things fleshed out. I know that the last time I sat through a presentation, they said like all the old clocks are out and the new clocks are in as far as epigenetic aging. Epigenetic aging clocks test epigenetic reprogramming therapies. Telomere tests measure telomere lengthening or shortening. Do not use an epigenetic test to tell me your telomere age, okay? Don't do it. And don't use an epigenetic test to sort out anything but DNA methylation. So when we look at senescent cells, we want to look at a test that looks at senescent cells. When we look at blood markers, we want to take consistent blood markers over time to test what's happening. So the whole rage about one test being able to do it all, it can't. We have looked at over 100 patients and the data does not, it just doesn't correlate. So you can have a very biologically young telomere length when you do a telomere test. That does not associate so much to your biological age on your DNA methylation. If you do a gene therapy that resets your DNA methylation and you catch one of those cells, you are going to have an extremely young DNA methylation test. So I think that there's a lot to flesh out in the industry, and a lot of it is based in fads. I've seen just recently what's entering again, which is great, is senescent cells. They've entered the spotlight again of the conscious mind in the media, and that's fantastic because they're definitely a hallmark of aging, and so we need to deal with them. And then immune senescence and immune system having some control over aging. And this sort of, I have a company that's working on that. They started in cancer, and now they're moving towards looking at epigenetic, not epigenetic, but cellular aging in the immune system and reversing it to reverse aging. And this is really exciting because that's kind of a new angle that is being looked at. But remember, you're going to have to reverse all of these things. And that's, I think that, keeping people's eye on the prize of all the things that we need to look at is the most important. So I've had epigenetic tests that, or DNA methylation, you might want to call them tests that say that I'm in my 20s. And I've had them that say that I'm in my 40s. And I don't think that it's indicative of a measurement until I do an DNA methylation reset. So we're looking at those therapies, but I'm working with a company that's actually doing those chemically, which is pretty cool. And this is a set of chemicals that they believe is resetting the DNA methylation in cells. And so I'll tell you more about that as that company gets off the ground. But this is kind of interesting for me because I have been a gene therapy focused person for a long time. And so entertaining a company that is using small molecules to reset aging at the epigenetic level is like, wow, I didn't picture that. But you can do it with the gene therapy. It's just the gene therapy, it's hard to target a lot of cells in the body with each gene therapy, and that would be quite expensive right now. So a small molecule approach is something you can turn on and off, and so that just kind of made sense to me.
Is losing weight or gaining muscle one of your New Year's resolutions? For me, adding muscle is always on my list, and getting proper sleep is a key part of that. A fascinating study found that poor sleep can reduce fat loss by 55% and increase muscle loss by 60%, even when you're eating right. But Magnesium Breakthrough by Bioptimizers can help. It's the only supplement that combines all 7 essential forms of magnesium, helping you fall asleep faster and stay asleep longer. Unlike basic magnesium supplements, Magnesium Breakthrough is specially formulated for maximum absorption, supporting deep restorative sleep that helps your body burn fat more effectively. I take Magnesium Breakthrough in the evening so I can get good sleep to support my fat loss and muscle recovery. If you want to try Magnesium Breakthrough, go to bioptimizers.com/modern and enter promo code MODERN10 to get 10% off any order. If you subscribe, not only will you get amazing discounts and free gifts, you will guarantee your monthly supply.
If people go and they try to take one test to measure aging, you're never really going to know what you've done, right? You might think, oh no, it doesn't look to have changed, or it looks to have changed a lot. You got to measure them all.
Yes. Well, there was a number of things in there that I would like to unpack. But yeah, I mean, we spoke to the person, Dr. Lautz, who was doing like glycan age, and he says like glycan age is not correlated very much with epigenetic age. I mean, there does not seem to be like one age.
No,
And
you got to do your glycan age, you got to do your DNA methylation, and then what the thing is that we have to change the paradigm of disease, and that's really hard. So we've tried to, as an industry, say, okay, here's the problem. There's aging, and then there's all these diseases that shoot off of it. And then what we do as an industry is we typically used to look to treat symptoms of those diseases. So if you had cardiovascular disease, then they would go after LDL, and they created statins. Okay, so you're treating a symptom, but it's of a symptom. But the reason why we're having a hard sell here, which makes sense, is because, okay, we had the symptoms of the diseases over here, then we've got the diseases, then we go back to aging. But aging itself is complex, and then aging branches out, and we have 12 agreed upon hallmarks of aging. We'll probably have more. Um, Not all of them will need to be treated independently. Some of them might affect each other. For instance, one of the hallmarks of aging is telomere attrition. You'll go in, you'll get a myriad of tests. They'll say you have short telomeres. Let's lengthen those telomeres and then see what else you have. Oh, you also have DNA methylation issues. Let's give you a therapy for that. Let's put you on these pills, or let's give you this gene therapy. Oh, you also have stem cell depletion. So we're going to need to take your stem cells, we're going to need to culture them, and we're going to need to expand them and genetically modify them so they're not old and put them back in your body. It sounds complex, but actually it's a way simpler way to deal with all of the diseases, and it actually takes you from aging to targeting them all. And what I believe is that today we have cardiovascular disease, COPD, dementia, et cetera, et cetera. We have these diseases of aging. But in the future, we'll have telomere attrition, mitochondrial dysfunction, cellular senescence. We'll have a host of maladies that are actually treatable, and those will keep you from getting the diseases of aging. I hope that makes sense. It's like it's such a big shift that I don't think we can do it at one time, and we still have to prove every therapy consistently works.
Yes. So going back to biomarkers, I assume you follow your biomarkers. Like, well, how often do you follow your biomarkers, and how are they doing?
The spreadsheets that we keep are vast, and they're essential because they're both pre and post therapy. So we went all the way back into the traditional work that regular doctors do because I had had two children. I had been pretty well tested through that period of time for my blood work and levels. And then we did all the pre-testing before I did the first gene therapy, which was the telomere lengths, the MRIs, and then we did blood work because I think at that time we didn't have much more. I remember we spoke to Steve Horvath, I think in 2014, but that DNA methylation test that he had, the first clock, it was really expensive and it was through the university. And I don't think we could come up with that kind of money at the time. We'd already blew everything on the gene therapy. I mean, no one in the company got paid for 2 years. We spent it all. So we had no money, and that we did as much as we did was pretty amazing. So then what happened? Well, just in the telomere length, so that was something that we had before. So we had MRIs in telomere length. Those were probably the strong biomarkers of aging outside of triglycerides and HbA1cs and things like that. We just saw like a cascade of benefit. My telomeres, so we use life length and SpectraCell. In SpectraCell, I think pre-gene therapy, my telomeres were like 6.8 or something like that. This year they're 10, and they just keep going. And we released a paper in 2022 on my telomere length. It was a peer-reviewed paper that came out to show that for every year after I received the gene therapy, my biological aging by telomeres went down about 5 years. And it had a big bump at the points where I would redo the gene therapy. So that shows us that probably the first gene therapy is persistently lengthening the telomeres. Now, this isn't only in the T lymphocytes because that's what they test. Doesn't mean that's the only place the gene therapy went. But then doing more gave us even another drop in biological age that is more less subtle, And then they continue, you can either think of my telomere lengths continue to go up or my biological age by my telomere lengths continue to go down. And we've never seen otherwise. And then in the life length, we look at the critically short telomeres. As far as my median telomeres and life length, they're like over 12 kb, which 15 would be embryonic. So so it's not just each type of test, it's how they test. We have another lab, a private lab that does my telomeres. They're in Israel, and the way they measure them is different. So the number is not as important as the lengthening. Okay. So it's just a 10 to spectracell is a 12 something to life length is I think I can't remember what the Israel group measures them at, but they said you can't look at that. It's the continuing of the lengthening. So of course, since that paper, a lot of people started applying to do the gene therapy.
Do you do any of the other kind of non-gene therapies, the more advanced ones, such as HBOT or exosomes or stem cells? Or is it just gene?
Um, I have tried an HBOT. I like that. A friend of mine in China, he had a one for an office. I guess it doesn't go up very high. I tried one at A4M one time that did go up to a very high pressure and it actually hurts my ears. I guess I'm a little bit of a wimp, but I have tried them a couple times. Um, stem cells, I tried this summer. We use those as a way to make sure that we reduced inflammation with a gene therapy that was applied to me. And we work now, BioViva mostly works in licensing deals, and we have a new company that's coming out who is going to take your stem cells. Yeah, yours, Richard's. And they're going to give you plasmapheresis, which cleans your blood. Then they're going to take your stem cells out. They're going to genetically make them young through reprogramming. They have 7 patents to reprogram your stem cells. They probably only need one of those. And then we're going to add gene therapies to them. And so I went down there to donate my stem cells. And so they said, let's give you they're kind of like umbilical cord or something like that. They're a neutral type cell, but it doesn't stay with your body because it's not your stem cells. So it has, I think, a regenerative effect for maybe a few months, maybe up to 10 months, but they can't implant because they're not your stem cells. But I thought it was cool that I finally got stem cells, especially since that's where my work started more than 2 years before my son was diagnosed. Before I had the idea for BioViva or anything, I was actually working in the advocacy of the use of stem cells and had not ever done them.
That that therapy, I mean, that flow that you talked about, taking the stem cells out, that sounds really interesting. But
Yeah, let me tell you why. Let me tell
hmm,
you why I'm interested in this. I've been looking for a company who would do this well, since we started BioViva. If we do gene therapy to your stem cells and we put your stem cells back in, there's no immune response. So you probably don't need an immune suppressant at all. We can do things like start targeting to the hypothalamus, in which loses stem cells and loses a gene called alpha klotho. We could start developing your own stem cell lines to build muscle mass. So follistatin might not be enough for some people because they don't have the precursor stem cells available that build those muscle cells. So you will get stronger muscle fibers, but might not bulk up in the way that is necessary to protect your body. So I think that this is going to be a very cool company. And again, no immune suppressant.
that sounds really interesting. Yeah. When's it going to be available? No, but
Um, Probably as early as next year.
wow.
We're working on investigator-initiated clinical studies. These are studies that you can move forward quite quickly. We've worked historically with a company called IHS. They've treated many people with gene therapy now. And this will go the same route as an IRB and an approval to use a technology. And we're also working with a premier professor in the United States who is already published in Nature. And we're going to work with him to actually direct these therapies to the hypothalamus. And so, unless something goes horribly wrong, we are on track to get patients in about a year. I think they've already got a waiting list of 52 people.
Wow. So, kind of changing tack a little bit. So, if you wanted to, if I wanted to have not stem cell, gene therapy now, right? I mean, you can't do it in the US. So, what would the flow look like? I mean, this is one of the things that I think BioViva helps organize through your partners, right? So,
Yeah.
yeah, what would that flow look like?
Well, that flow, so if there are new locations that are coming online, the Bahamas just signed into law a new regenerative medicine law that will allow the technology there, but you do have to go through a platform to get it there. We'll probably go through there. So you might be able to go somewhere like that. You might be able to work with a company that we already work with, like Integrative Health Systems, who they don't do the gene therapies, but they connect you with a doctor who will. You would go through lots of doctors' consultations to understand, they would need to understand what you want to treat. Then you would have required testing that you would need to do. If you were getting something for dementia, you would need a functional MRI, you would need a diagnosis, you would need your blood work, you would need a myriad of test kits sent to you, and then we have those all analyzed as you're waiting for your therapy. Then you would fly to a location in which you can legally access that therapy. It would probably be a 1 day treatment. You'd probably stay on site with the doctor for about 3 days, probably have dinner with them a couple times, and then you would fly home. And then the big work starts because then we're going to run you up for data and we're going to be relentless. And you're going to have to follow up with your MRIs and your blood work and your tests and your 20 billion of this and 20 billion of the other thing, because we can't make better therapies unless we know how those therapies work. So we can't give them to you. Other people can, but what we can do is look at the data.
And so BioViva kind of organizes this process.
No, we don't. We on
Um,
our side, we build gene therapies and we
right.
license them out to medical doctors and companies who have the legal right to use them in their location.
Okay. So all this pre-work, you need to get all these different things and consultations. So who is there one entity that would organize that kind of process?
Right now, Integrative Health Systems, there's also a Swiss company called the Longevity Concierge Agency, and you can find them online as well. And they're fantastic. It's a Swiss group. You could do anything from stem cells in Switzerland to, HBOT in Dubai to gene therapies where they're available. And so, yeah, so that if you're looking for a bigger network of dossier, then you might go to them. If you were just looking for a gene therapy or stem cells, you would go to Integrative Health Systems.
Um, if it's an answerable question, suppose you wanted gene therapy, what kind of budget and what are the parameters that make it? I mean, if you have two gene therapies, does it cost twice as much, or is it 1.5 because you've got all the other costs?
That's a good question. I don't know. That's not really my area. So that's for the companies that they have to generally go to a manufacturer that can make a grade of therapy that would be acceptable. And then it's based on the going rate at that time through that company. So for instance, during COVID, almost all gene therapy stopped because the same reagents were the ones that were used in the immunization. And so the cost of even gene therapy clinical trials were leaving the United States because they couldn't wait actually to get a gene therapy besides afford one. The wait lists were incredibly long. So I think that it's probably a day-to-day thing. We hope to eventually build manufacturing so that the whole pipeline is closed. But right now that would be not very economically sound because there's so much manufacturing AAV and we want to focus on CMV.
Right. Are you seeing more people? Are you seeing like an uptick? Well, I mean, it's difficult because like there was a 3 year break with COVID, but are you seeing an uptick in the number of people who are willing to go and have gene therapy?
Yeah, the thing is that we don't have contact with the patients directly. We get
Mhm.
anonymized data, but we see a lot of anonymized data now coming through as pre-data to gene therapy. So we know that more people are translating and are interested in getting it, and that totally makes sense. I mean, for instance, with telomerase reverse transcriptase, the number one killer of COVID-19 patients was cellular senescence. And that's short telomeres predominantly in your T lymphocytes. So your immune system can't divide cells in order to attack an infection. And the body goes into other immune responses in order to kill the virus that end up killing the host. So it's a terrible thing, and I think that a lot of people learned more about not just aging associated diseases, but cellular senescence and immune senescence during the pandemic.
Yeah. The whole idea of the immune system being so central to aging and fixing that solves a number of problems
Yes.
is, yeah, a number of people that we talk to have this kind of idea, and this is their approach, which really makes sense.
Yeah, it's a really important thing, and we have one company, as I told you, that feels like they have evidence that if you stop repressing the immune system, then the immune system actually knows how to rebuild the human body. And that's beautiful. The only problem is you do have to address cellular senescence and shortening telomeres. You can only rebuild with the cells and the stem cells that you have that can actually create healthy daughter cells. I mean, when we look at senescent cells, I mean, senescent cells are holding a line, right? If you're a I don't know if I have a piece of paper here that I haven't written on. Here's a pet prescription. Pet prescription on one side. Oh, rabies vaccine. Very good dog. If this was your skin and you've damaged it over and over again, what happens is as you can't repair it anymore, you start to get holes in your skin. But you don't because senescent cells sit there. Something has to plug the hole. That happens in your bone marrow. It happens in different parts of your body, in your organs like liver. So often fat will be the thing that will start to deposit when cells are not readily available to heal a space anymore. But we are a long-lived species because we use senescent cells very well to plug those gaps. So you need to make sure that you have healthy cell division so that you don't run out of healthy cell division because, something will eventually get you if you don't look behind your shoulder constantly. What have we missed? And I think, with aging, what will probably happen in like five years or so, we'll start to feel really confident because you're going to see people looking younger and healthier consistently in the public who are part of these therapies. And then we'll start to find, hopefully we won't, but we'll start to find little holes, gaps that we're missing. And that will be the necessity of science to come forward and fill those gaps.
Yes. I would think also that would have a change in the regulatory environment. If you have people who are clearly showing the benefits, then there would be far more pressure to make it more widely available and to make it less difficult to have.
Yeah, I feel like we have a couple of really good papers that show that already. And when we did a pre-IND a couple of years ago for dementia with the data that we had, you know, we were told to go back and do $8 million more animal work, and I just thought it was absolutely ridiculous. So, you know, we're more interested in partners that can work legally in their locations and help patients. I think that eventually, and we will see it in the next couple of years, the regulatory environment is going to change by force and then hopefully come back together as something that is more suited for patients rather than for lobbying and small molecules.
Yes, yeah, that's what I think the pressure will build once it's been shown. So there's been a lot of investment actually in in longevity recently, right? Altos, Calico, Retro Biosciences. Has that made any difference in your area?
Yeah, of course, because the heat is building up and more people are interested in us and keeping us running and see the necessity. And actually it has a flip side to it too. There's a group of people, of course, who want to see us move forward and not big companies. Number one, big companies are more held to regulations than small companies like ours. They're the same regulations, but we can, you know, humanitarian effort our way into helping patients, whereas the bigger companies are not trusted as much to do that. I mean, you can actually meet our patients, you can meet their families if they consent to talking about it. Um, Also, you know, we're trying to democratize the cost of healthcare. We're a George Church company, which means we have to somehow come up with an affordable gene therapy and lickety split, and that's a tall order, but that is the goal, is a combinatorial gene therapy that everyone can afford. And so I just really appreciate that, you know, people will back us instead of the monsters who go through an exorbitant amount of money and may or may not achieve the goal. I mean, we are pretty much first to everything. We were the first to treating a patient for aging. We were the first to treating patients for dementia. We were the first to treating aging people with sarcopenia. We have done monogenic disease. We have done all sorts of things. We have no trouble with speed. We always have trouble with having enough money to accomplish everything that we need to do.
Yes, that seems to be a kind of a common issue with small companies, which is not surprising.
Well, the thing is, we're really tight. It doesn't take us as much money, but you have to have money going into projects, right? And the
Yeah.
projects have to be overseen and they have to be kept on track.
So at the moment, you are doing, uh, I would call them like point solutions for gene therapy, right? So one for follistatin and one for clothions. Do you see reprogramming as kind of the way forward rather than,
We
yeah,
will wait because remember we went back and there's different type of therapies for different things. So we can reprogram. We can do that. But when you partially reprogram, you don't get telomeres. So what you get is an animal that lives a little bit longer. They look good, but they die. So if we reprogram and lengthen telomeres, that's what we're doing with this new company with stem cells. They're doing all the reprogramming. We'll lengthen the telomeres and or we'll add function genes. So we're a combinatorial gene therapy company. Number one, we do single gene therapies, but we are focused on curing all of aging. But if you just reprogram, and we can reprogram, it does not cure all of aging.
yes. I was thinking, so that made me think about, so we're doing, or not we, humans are doing reprogramming tests in mice, but mice naturally express telomerase. So even if you could do it in a mouse, I mean, that's always true, but it would be less. It doesn't mean that it would work in humans because humans do not express telomerase naturally.
Yeah, we
And
do in some cells. Oh, so
yeah.
when you're talking about reprogramming, you're just talking about telomerase. Yeah, so that
N-
you can turn on telomerase in mice. They live longer, but they still die. You
mm,
know, so it should have a bigger impact in humans. They just made a mouse at one of the universities called Hoot mouse. And it is the first, they're claiming it's the first mouse strain that actually has a functional copy of telomerase reverse transcriptase similar to humans. It's the humanized version of a mouse. I personally, outside of general safety, don't think anything matters that what happens in a mouse. If it doesn't kill it, we still don't know what will happen in a human.
yeah, I'm with you. Yes, it's. I thought that mice actually have telomerase kind of naturally. It,
They have long telomeres, but
yeah.
their telomeres still shorten, but they
Oh,
have really long telomeres. It's their rate of shortening that is different. But mice typically don't die, so there's always the shortest fuse, and telomeres are generally not the reason why they die. We showed in our paper that came out of Rutgers that if you lengthen the telomeres, the mitochondria actually look healthier, definitively. The metabolic control was definitively better. That might have been why they lived longer. But there have been many studies where they've lengthened telomeres and the mice have lived longer.
now that you mentioned mitochondria, that also seems like one of the things that may not get caught with the other gene therapies and especially the mitochondrial DNA may continue to deteriorate over time. And so you may need a therapy for that.
We have there was a therapy I took in 2020 called PGC1 alpha, and it's the master regulator of mitochondrial biogenesis. And even though we see that follistatin does benefit the mitochondria and TERT benefits the mitochondria, if you really wanted to target mitochondria, you would want to pull out PGC1 alpha.
How is how is your work with CMV going? Because we talked about it like I think last time you said that you were moving to CMV. Um,
Yeah, so we're excited about CMV. So right now we've got data back from non-human primate fibroblasts, and we showed that the CMV that we want to move forward in humans would transfect the fibroblasts of the non-human primates, which actually CMV, of course, like everything worth doing, is going to be hard. And when we look at AAV, so that's where we started our work. Problem is, it's a very small vector. It can barely deliver a small gene, you know, and that makes it tough for us. We wanted a large vector that we could deliver multiple genes, and that's what CMV does. Plus, it was redosable in animals. But here's the caveat: mice have their own CMV. Non-human primates have their own CMV. Every species appears to have its own CMV. So that makes moving it forward really difficult. So we modified the capsid to see if we could get transfection in non-human primates with the human CMV, and we did. So that was a big feat. And then they're working on starting the non-human primate, the proper non-human primate study now. There was a lot of debate that happened over the last couple of years of what the protocol would look like, what would be required, and whether we would use a human CMV or the non-human primate CMV. The reason that you would do the non-human primate CMV is you just want to show that CMV can deliver genes in non-human primates, which is a great study, but it's more like a research thing. If you use the human CMV, you're trying to show that the CMV is safe and has some effect, even though that's not the model organism's version of CMV. So we decided to go with the human CMV, and the whole thing just became a lot more complicated than it should have been. But there you have it. Really, yeah.
Okay.
I need Elon Musk's money. I need to solve aging like tomorrow, and this is going too slow.
Yeah, I can see that it's so complicated, and because you're leading the way in so much of this stuff, then everything is you, yeah, you have to break the path, and so every step is so difficult.
Everyone's like safety, 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 and so I just keep injecting myself with gene therapies. I'm like, it's safe. Let's go.
Yes, yeah,
Safe enough.
I mean, it is a diversion, but I think the thing is that when you get older, um, the safety, the risk profile of your thinking changes. So if I'm 80, then I don't worry so much about some of these things than if I was like 20, because I've only got like 10 years left if I'm lucky. So the whole, yeah, whether you need to have the same approach or is not clear.
Yeah, there's a lot of people dying who need access to the gene therapies and all of regenerative medicine. And so kind of we're the vanguards of trying to push that to make that happen and opening up in any area of the world that it's legal to do so that people can begin to access it. There's a beautiful story. It's not a beautiful story yet. I hope it ends as a beautiful story, but there's a boy named Archie. He's in Ireland, and it would be great if you promoted this. He needs a gene therapy. He has Duchenne's muscular dystrophy. He probably has 2 months, or not 2 months, but 2 years until he's in a wheelchair. He qualified for the US gene therapy, but they need 3.2 million euros to get it. And the future will not look like this. In the future, we will not put paper money in front of a child's life. And so what's beautiful is people are coming out, sports players, famous sports players all over the world are coming out, from the Oakland Raiders football in the US to football slash soccer players, as we call them in the US, in Europe, are coming forward to help him raise that money. But um, I mean, this is one of the critical turning points for gene therapy. If it's too expensive, if there is a cure, but it's too expensive for children to access it, who have their whole life ahead of them, then we've done something incredibly wrong. And they're just waiting for him to have that amount of money before they treat him. And I'm ashamed. I'm very ashamed of the world for that. And if we go after aging-associated diseases, we would be able to scale gene therapy to an affordable cost within a very short period of time and make these monogenic childhood diseases a free lunch. We would just be able to make one and give them the therapy that they deserve. So it's beautiful that people are working together. Good people have come together to help him raise the money. It's really terrible and shows you how much we value life as when we're a business. So when you look at medical tourism, the most expensive single gene therapy there is probably $300,000. You're going to get full care from a physician, a hospital setting. You're going to be cared for days. You're going to have people analyzing and following your data and everything else. All of the bells and whistles, just like these US approved therapies, but for a fraction of the cost. And with more people using them, that cost will go down, 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 down. And so if you already look at the scale of what you can do through medical tourism, it's already so much less cost than what happens when we let a system run the monies and cents analysis on the Dalian qualities of someone's life.
That is pretty terrible. And I mean, it's not inherently that expensive. It doesn't inherently cost 3 million to deliver this therapy. It's just the way the system is set up that that cost is there.
Yeah, and then they're saying that, oh, well, some of these kids have vomiting and they have, all these other things for days, or why? We don't see any of that. Why? What are they doing? I don't know. I don't know what they're doing. So yeah, challenge to the healthcare system. Hey, why not cure a kid if there's a cure?
What? So we've talked about what BioViva is working on. So you're working on an, a number of things. You were talking the reprogramming with small molecules and the stem cells.
That's a different company. So those are
Oh,
all different companies. So we've licensed out to China. We've licensed out, hey, to a group at Roaton, Unlimited Bio, who's going to be doing some gene therapies there. We've licensed out to a company called RegenCell, and they're the ones that are specializing in stem cell reprogramming and then gene enhancement.
okay. So hmm. So bio are these related to BioViva at all, or is it just it's kind of related to you?
It's all related to BioViva because it's all BioViva's IP. So since
Right.
the time we started in AAV. We built a lot of IP and know-how there, and then we traject into CMV, in which we're building all the IP there. So we're just a platform company that builds gene therapies. And then we just so happen to be run by a humanitarian that gets over involved in patients' lives and thinks everybody needs a gene therapy, and especially if they're dying. And then I work on regulations, a third of my work time. I work on, education, and then I continue to raise money for BioViva, the company, to make new IP.
Just in kind of in closing, what what are your thoughts about kind of the future of healthcare? I mean, healthcare is definitely not addressing aging or chronic diseases at the moment very well. Uh, do you feel hopeful about that being able to change in the near future? We've kind of touched on it, but just kind of wrapping up your thoughts on that.
Yeah, I mean, I think we'll move from a sick care system to a healthcare system. I think that we need to prove to governments that the savings of treating biological aging is more than the lobbying dollars. And I think that right now that's the hard sell. I think that we have the technology to already deliver on David Sinclair's paper of just slowing aging by 1 year. And that would deliver on a, $38 trillion cash purse for the country that looked to do that. And I see a myriad of countries stepping forward with their own funding mechanisms in the Middle East, in China, in different places of the world, literally governments coming forward to deliver on that, to save money on the burdening healthcare system. I think that the US specifically, and the UK, and a few of the EU countries definitely need to step up and join that. I think that we need to de-risk technology. I think we've become so risk averse that now we let patients die that probably don't need to die, just because we don't want to try, because it seems too hard. But once we push this baby out, labor is hard. I have two kids. Once we push this baby out, it'll be a big shift, a big change, and we'll be able to, bring the whole world up to what is actually real healthcare, and it will continue to evolve. All medicine is life extending medicine outside of euthanasia. So it's like every bit of it was designed to help people live longer and healthier. So I'm not trying to poke at anyone. If I'm poking, it's because people are dying because they need access to new medicine. We can't get stuck in the Polaroid moment. Polaroid was this company that thought it was at the height of everything, that that it couldn't get better than the Polaroid camera, and they stopped putting money into research and development. And what happened? They fell out until they became a retro gimmick again. So we don't want to be that in healthcare. We need to deliver on what humans are building, and what we're building is way more immense than this. If we can't take this step, we're not going to make it to the society that we need to be in order to survive. This is the most simple step of the whole process. We have been building since humans began to evolve. There's a time in history we get the spark gene and we can suddenly consciously understand time and start to work through time. And at that same time, we start to build things. All written history shows that we were building things. And that is it, one page at a time, we're understanding what we're building. The emergence of gene therapy and AI, they're showing up because the time is now. The time is now to build something bigger and to fight for our biological relevance in a changing world in which the climate is about to stomp on us, in which, survival necessity is hard. If we're still debating whether or not we want to cure grandma and grandpa with technology that we see in animal models and now we're getting a good image in humans is effective, we are way too far behind our schedule. We need to keep building and making a better future, and this is just a small part of it. We have so much more to do. So I certainly hope that we'll be able to achieve this. Good
Yes.
luck.
Yeah. Good luck. Yeah, I'm with you 100%. All the pieces seem to be there. It's just putting them together.
Yeah.
So, where can people follow your work and BioViva?
Oh gosh. I blush. Well, I have a lot of what I call value added pieces, like cool stuff that's going on in science, and that's mostly what I do. My team and my friends are like post a picture. I occasionally post a picture of where I'm at, which I think is a little bit vapid. But if you want to follow cool things that are happening in science, look for bioviva-science.com. Look for us on Facebook, Twitter. You'll want to follow BioViva and my Twitter account because we alternately share. They share things that are more relevant to their technology. I share things that are more relevant to general gene therapy and everything else. Where else are they? They're LinkedIn. LinkedIn. You can follow Integrative Health Systems as well. They're on LinkedIn. Follow all the companies that we're working with. They're like the most amazing people in the world doing the coolest stuff in the world because we're just a building block to them and then they take it and make something awesome. And I think RadFest this year is in Vegas and Aubrey de Grey is bringing LEV to RadFest. So it's LEV/RadFest. His chocolatey goodness has run into the peanut buttery goodness of Radfest, and now we have a Reese's peanut butter cup.
Okay, that will be brilliant.
And so, yeah, I just come and find me.
Liz, thank you so much for joining us. It has been great talking to you again.
Yeah, absolutely. If you ever want to sit down for a fireside chat, I'm always here.
Thank you.